Let's start with simple space maintenance. Space maintenance is one of those things that every general dentist should be aware of and should be able to evaluate. This is what happens when we don't evaluate space. When we lose a primary tooth early, either a cuspid, a primary first molar, or a primary second molar, teeth will shift. Either anteriors will move off of midline, or adult molars will move forward. Adult first molars will move forward, and we will lose space. And when that happens, we either block out erupting cuspids or erupting bicuspids, and we will block out adult teeth from erupting into their normal position. Now when you see something like this is a lot harder to correct than holding space in the first place, isn't it? So what I'd like you to do is to be able to look at children during their growth and plan on evaluating their space and making a decision on whether you need to hold space or regain space, rather than ignoring it and ending up with a situation like this. Because when you have a situation like this, your decisions become different. What your decisions become when you have a cuspid sitting high like this is, can I distalize posterior segments and make room for the cuspid, or do I need to extract a bicuspid or a molar, or do air rotor stripping, or do some other technique to regain space for this cuspid? And those techniques are certainly a lot harder to accomplish. So the early loss of primary teeth causes a reduction in arch length, and it directly affects the eruption of the adult teeth. Now, here's what happens. As you can see, when you lose a primary cuspid or a primary molar, you want to be able to evaluate the space from the distal of the lateral to the mesial of the molar in each quadrant. That is the space that you want to be able to evaluate. You need to have enough space for the eruption of both a cuspid and two bicuspids. That's the amount of space that you need. And the same thing needs to be said on the lower arch. You need to evaluate the space from the distal of the lateral to the mesial of the molar on all four quadrants when you lose teeth. If you have a situation like this and you do not put a space maintainer in, these first molars that you see here are going to drift forward and block out the space for the erupting bicuspids and cuspids. Guaranteed. Now, the only time that you may not need to put a space maintainer in is if eruption is imminent. And if you look at an X-ray or you see, the cusp tips popping through here, then it may not be necessary to put in a space maintainer. But other than that, you need to have something in there to maintain that space, or you can be guaranteed that you're going to have space loss and crowding. So the key to preventing a serious malocclusion when you see the loss of a cuspid and or a primary first molar and a primary second molar, the key to maintaining that space is to get a space maintainer in place. Now this is a simple space maintainer. A simple band and loop. Now there's a right way and a wrong way to even use this appliance, and we'll talk about that a little bit as well. This is a crown and loop, also a simple space maintainer. I'm going to show you three or four different kinds. This is also a space maintainer. This is called the TP arch, or transpalatal arch. This appliance works because when you go across the arch, it prevents the molars from going forward because it can't go into a narrower part of the arch when you come across the palate. This is the appliance that I wish you would use under most situations, even when you have a unilateral loss. When you lose even when you lose primary molar, first or second molar, or in a primary cuspid on one side, you're often going to lose it on the other side. And I would prefer that you go to a lingual arch rather than a single unilateral space maintainer. And there's a few reasons that I would prefer you do that. First of all, if you lose it on one side, you're often going to lose it on the other. That's reason number one. Reason number two, if you lose it on one side, odds are you're going to take a quadrant impression and send it to the lab, because that's the easiest way. And if you take a quadrant impression, I can guarantee you that you will not have done a mixed dentition analysis. You will have just looked in the mouth and you will have said, oh, I've lost a tooth here, I better maintain the space. And you take the impression and you send it to the lab and you get a unilateral space maintainer made. Before you put a space maintainer, it is imperative that you do a mixed dentition analysis to evaluate whether or not indeed you need to truly maintain space or regain space. And the only way you can do that mixed dentition analysis is to take a model and do the actual measurements. So all those guys and gals who are sending us little unilateral impressions, I pretty much know you haven't done your homework. Not a really good thing. The other reason is from a pay management point of view. If you have to deal with insurance at all, generally speaking, insurance companies want to pay for it one time. They don't want to do it again. So, especially if any of you have to deal with Medi-Cal for these kids, and a lot of you have to on occasion. So they're only going to do it one time. So just trying to give you little hints as we go along here, that what you want to do here is you want to do it one time. Now the other reason, as I told you, there are many reasons that I want you to do this. Notice that there are distal stops at the distal end of those laterals. That's to prevent those laterals from moving off of midline, which is very critical. Because when you lose a cuspid, as in this situation, not only can molars drift forward, but when you lose a cuspid, anteriors can drift off of midline as well. And when anteriors drift off of midline, you get lost space as well. And that can affect the method and the appliance that you should be using to regain your lost space. Yes, question?
In the first slide you were showing that the canine was kind of super-erupted.
Yes, out buccally.
Yeah, buccally. But if you, in order for you to gain space for that canine, you're going to be shifting molars, and then you're not going to be in class 1. Would you consider doing that?
The question was, in that one case where I showed you at the very beginning where the cuspid was sitting out buccally, and I wanted to regain space, and I made the decision to move back my molars and Veis in order to allow that cuspid to drop in, and I wasn't going to be in a class 1 molar relationship. Would I consider doing that? Personally, no one died from a class 2 molar relationship that I know of, and if it gave me a decent class 1 cuspid relationship and gave me excellent aesthetics, I would probably do it, personally. But I would that's a very simplistic answer to a much more complicated question, because I would have to look at all the records to see what the skeletal relationship was, to really look at the upper and lower arch together. But a simple answer to your question is, I don't just look at the dental classification, but I wouldn't object if that's the only problem that it created. That wouldn't bother me particularly. That's right. Okay. So when you have lost space, when you have lost primary teeth early, you want to maintain space by getting a lingual arch in. You want to have distal stops whenever possible. And now the question is, how do you go about making the decision whether or not you need to maintain space? There's a question, maintain space or regain space. Yes, sir.
Concerning the transpalatal arch wire.
TP arch, yes.
Is there going to be some expansion to those first molars that wire might keep from happening?
No. Mm-mm. The question was whether or not having a transpetal arch wire, whether that can eliminate expansion in here. It can. You can design this arch wire with a loop in here to expand it. The answer to your question is, before you put any appliance in, you have to evaluate the arch width and the arch length and decide what you need to do. If you're looking to just hold these molars where they are because they are ideally placed in the arch, both in their position, in a mesial distal position and in their arch width, then you're going to use a transpalatal arch like you see here. If they are in lingually and you would like to get them out buccally, you could put a loop in this wire and expand it by opening the loop and push them out buccally. So the more in-depth answer to your question would be you have to look at the models. But in this particular situation, as an example, I'm just showing you something that would hold these teeth where they are. Okay? Yes?
Would this be the button type that they had you make it a button palatal? They used to make an acrylic button in the center there.
So putting an acrylic button here as a spinner, you mean?
Whatever reason. I don't remember.
Well, there are many variations on a theme, and the textbook. I think you've all seen the two copies of the textbook that are back there. There's both the inoperatory edition. Dan, walk those up here, if you wouldn't mind. Throughout the day, you're going to see a ton of appliances, and the truth is that there are 100 variations on a theme for appliances. What I've tried to do is to show you every different type of appliance I could and all the component parts that make up an appliance. And the answer to your question is, this is like the appliance that they showed us at SC, but you can put a spinner bead on. Right over here, you can add a little spinner bead to help retrain the tongue. You can carry, you can carry a wire all the way around the front here. You can add a cage on here for a habit appliance. There are many ways that you can change this appliance. This is just an appliance right now called a TP arch to help maintain arch length. Okay, so let's move along. You have a situation where you lost teeth and you need to make a decision. The first thing you need to do is to do a mixed dentition analysis. I'm going to show you the simplest way to do a mixed dentition analysis. In answer to your question, tomorrow you will get a handout on the mixed dentition analysis, because this is not something you want to take notes on particularly. Okay, so the mixed dentition analysis is just a way for you to evaluate the arch length to see if you have enough room in the arch for 3 teeth in each quadrant, the cuspid and the Veis. There are many different methodologies to do this. The simplest way is this. You sum up the mesial distal width of the 4 lower anteriors from the widest part of the contact point. So let's just give you an example. The average lower central is 5 millimeters and the average lower lateral is 6 millimeters. So it's 5 millimeters and 5 millimeters, that's 10. And 6 millimeters and 6 millimeters, that's 12, correct? 12 and 10 is 22. So you add up the 4 lower anteriors and then you divide that in half. So 12 and 10 is 22, divided in half, that's 11. Everyone follow me so far? To that number, that constant number, for the lowers, you add 10.5 millimeters to that for each quadrant. So 11 and 10.5 is 21.5, correct? 21.5. What that means is you need 21.5 millimeters from the distal of the lateral to the mesial of the molar in each lower quadrant. That's the space that you need for a cuspid and 2 bicuspids to erupt in the lower arch, in each quadrant. On the upper arch, it's the same thing. You add the 4 lower anteriors, not the uppers, same thing. 4 lower anteriors divided in half, that's 10.5, that's the constant. And the upper arch, instead of adding 10.5, you add 11. So 11 and 11 is 22. So from the distal of the lateral of the upper to the mesial of the molar on the upper, you need 22 millimeters. for the cuspid and the Veis. So that's the number that is needed. Now, all you do is on your actual model, you go and measure. So you measure on the lower from the distal of the lateral to the mesial of the molar. If it's greater than 21.5 millimeters, you have enough space. On the upper, if it's greater than 22 millimeters, you have enough space. If it's less, then you don't. Simple enough? Everyone follow me on that? Okay. So you sum it up, add the 4, then you actually measure and compare. So if you measure from the distal of the lateral to the mesial of the molar, you compare. And if you have enough space, you're good to put a space maintainer in. If you don't have enough space, then you have to decide what you're going to do. How are you going to regain the space? So here you can see that we're sitting at 21.5 millimeters, which means you have enough space. But let's say you have enough space. All that means right then and there is you need to put a space maintainer in and hold the space until the Veis and the cuspids come in. Now let's say that you don't have enough space. You have to ask yourself, why not? Right? Well, if you don't have enough space, there's only 2 reasons you don't have enough space. Either your molars have drifted forward, correct? Or your anteriors have moved off of midline. Isn't that right? Or both. Everyone follow me on that? So, it's important for you, when you choose an appliance to correct the problem, that you understand what out of those 3 choices you actually have. Because if you don't figure that out, you're going to choose the wrong appliance and you're going to get the wrong result. So you need to figure out what has actually happened. This gets a little more complicated, so I want you to just think this out for just a second. You need to make sure that you're looking at these teeth, and the way to figure this out is just to visualize and make sure that you're trying to see what these teeth look like if they were on midline. That's all you need to do to figure this out. So let's just look at the lower teeth for a minute, because this is the most complicated part of this. Let's just say you had a kid, and he had lower teeth that just looked like this. With his teeth apart, and you're looking at the kid, teeth apart, look at his lower teeth and look to see if his centrals are on the midline. If his centrals are right on his midline, that's great. Then you have nothing to worry about. Then if the centrals are in the midline and the laterals are on the midline, then you can comfortably measure from the distal of the lateral back to the molar and get an accurate measurement. If they're not, if you see a shift to one side, then you need to mark the midline on the model so that you can get a corrected lateral position. So let's just say that the teeth have shifted off to one side. Everyone following me so far? So if the teeth is shifted off to the left, let's say, my left, you need to look at that patient and mark the midline right on the model. Then, measure the mesial distal width of his central and lateral. Let's say it's 5 and 6, and that's 11 millimeters, right? Take a Bowley gauge, open it up 11 millimeters. Touch it to the mark on the midline that you marked on your model, one side of it. Let the Bowley gauge touch on the model on the other side, and where it touches, make a mark on the model. That's where your midline, that's where that lateral should be if your teeth were on the midline. Make a mark on the model, and then measure from that mark back to your molar. Okay? And take that measurement. And if that measurement is short, it then tells you that you need to move the molar back. If that measurement is normal, it then tells you you need to move the midline over. Does everyone understand? Have I lost anyone on that? Yes?
On the midline, always you just follow the upper center.
Follow not the upper central, so that's an excellent question, the skeletal midline. That's why I said with the teeth apart. Okay? Look at the face, go straight down the face, look at the skeletal midline. Okay? Don't go by the upper teeth because they may be shifted too. So you have to do that for both the upper and the lower arch wherever you've lost your teeth.
Let's say you had 2 millimeter shift to the
Yes.
to your right side,
Mhm.
and you had 11 millimeters. So
Yes.
so that makes it 13 millimeter if you added 2 millimeters.
Yes.
So when you mark the 13 millimeter, how do you do that?
Okay. If you went down the midline and the teeth were shifted over, let's say they were shifted over, let's go to your upper. Let's say your upper were shifted off to one side, to the right side, 2 millimeters. You marked it here, there was your midline, and it shifted over 2 millimeters. You're going to draw a line that will come onto your lateral, it will mark the lateral 2 millimeters over to the left, because it shifted over 2 millimeters. And you mark the midline right there, you measure that, it will mark actually 2 millimeters to the left, and you measure from where that, you're actually kind of shifting the teeth over basically to where they should be. You're moving it over by marking it 2 millimeters over. So the line that you're measuring from is actually 2 millimeters marked onto the lateral. So you're not measuring from the distal part of that lateral, you're measuring 2 millimeters onto the lateral itself. Can you visualize it now? Because that's where the lateral should be if it had shifted, if you moved it back over to midline. So what that's telling you is that that midline needs to be shifted, which means you're going to make a completely different appliance to move that midline over. Okay? Everyone follow me on that? Basic stuff we should have learned in dental school, but that we didn't. Space maintenance. Every general dentist should know space maintenance. This is a space maintainer. Now, this is what we all know as a flipper, right? Yes? What's wrong with this appliance? One of the things I'm going to talk about is things that we see in appliance design today too. So that I want to get you to be experts on appliance design so that by the end of tomorrow, for those of you here tomorrow as well, when you get an appliance, you're going to actually have it work. So that when you get one in your hands and you pull out on a spring, that it won't just pop out of the patient's mouth, that you're going to actually get it to move the tooth. So what's wrong with this appliance design? Who can tell me? Anybody?
Class.
The clasps. Who said that? What's wrong with the clasps?
It's not attached to the tooth.
Well, they're Adams clasps, and Adams clasps are not particularly retentive on primary teeth. They engage under a mesial distal undercut, and they're very retentive on adult teeth, but they're not real retentive on primary teeth, so I don't really like Adams clasps on primary teeth. That's one of them. The other thing is the extension back here. I mean, we don't want to make our patients gag, so that's a little excessive, wouldn't you say? The other thing is, if you remember, again, going back to our basics in partial design, that you want retention as close to the fulcrum as possible, right? So wouldn't you want some kind of retention somewhere up here? Because there is your fulcrum, right? So it would be nice to have some kind of clasping up near the cuspid. That's why this is called a flipper, because that's all they do is flip this thing in and out of their mouth. Now, a better clasp design would be use C-clasp with a little composite button that you see here. One of the things, if you're like me, I can go to any one of your offices and I guarantee I'm going to find your composite drawer. You know what I'm talking about? Where you have hundreds of different types of composites, because I'm not allowed to go to meetings with my credit card anymore because I buy everything new in sight. I have to have it. I have to have it. The latest gimmick, right? So I get a card to go to meetings with. It says, please return me to. And that's it. I don't get to buy anything. But I can take out any composite that you have and you create composite buttons. That's what you want to be able to do, to create retention like you see right here. and use a little C-clasp. That's a better method of retention for a lot of your appliances. Now this is even a better design. Now you may say, well, why are you showing me space maintenance in anterior arch, the anterior part of the arch? Do we need that? Well, absolutely. Why do we need to have space maintenance in the anterior part of the arch? For aesthetics, phonetics, and function. Okay? When you lose those front teeth early, where does that tongue go? Straight forward, every single time. When you swallow, where does the tongue normally go? It goes up against the rugae, and as you swallow, it goes out laterally to develop that maxilla out laterally, to develop the maxilla normally. And if you lose that, the maxilla will not develop normally. And we all know that the maxilla must develop normally to have normal growth and development. If you have an underdeveloped maxilla, it will create everything from a crossbite to a skeletal class 2. So it is imperative that we get a normally developing maxilla. Yes?
If you have something like this, would that prohibit the growth of the maxilla?
No, because it is usually bonded. The question was, will this inhibit the normal development of the maxilla? It's bonded normally or placed on the primary molars, as you see here. And you, again, have to look at the age that you're putting it in the patient. You're usually putting it in a younger patient, age 4, 5, okay? And usually you're taking it out right around age 6 and age 7 when the adult anteriors are coming in, so it usually does not interfere with growth and development. This is called a Groper appliance. This is an excellent appliance. These little mesh pads are specially designed to integrate into the teeth. And it keeps the palate clear, which gives normal speech. But even with this appliance, there's a couple things with the design that I like to improve upon. And because the patient will often want to get their tongue underneath here and try to flip it loose, which causes the solder joints to break here. So I will usually put a little rest seat right here and cut a little groove into the cuspids and then bond a little composite over the rest seats to hold it in place. So this is designed by John Groper, who is a pediatric specialist. I often teach with him. Yes?
You're recommending with this on all patients with the early loss of primary anterior?
All patients. If you lose teeth early, I think it's important to maintain the space for those reasons, for aesthetics, phonetics, and function. And so, again, it's timing, it's age dependent, it's arch size dependent. So my answer to your question is all patients, almost always I will put some kind of space maintenance in patients from the age of 3 on up to the age of 5 who lose anteriors early like this. 1 tooth, generally not. 4 teeth, almost always. It's very aesthetic. Now, we call this the grandma pleaser because they're the ones who usually want it and the ones who generally pay for it. But there are many reasons for it. It is not just for cosmetic reasons, although kids can be very cruel to each other, as you well know. So that is, again, aesthetics is one of the reasons that I talk about. But it is also phonetics, and the main reason I do it is for function. Now there are, we used to just have acrylic shades, but we now make this in composite shades. The composite shades, the new composite teeth are far superior. They don't pick up stain like the old acrylic ones used to do. And it took us years, it took space maintainers years to develop a composite tooth for this. You would think, oh, it's just easy, just plop composite in there. But the laboratory technique to actually make this is not easy. But we finally have it. It just took us years to do it. So you should all know that you can now get this appliance done in a composite crown. This is an example. This is a patient who lost these teeth to baby bottle syndrome. This is on the day of delivery. And I lost the slide. This is on the day of delivery. I don't know what happened to the final on that. Here's another one. Believe it or not, we're going to save this cuspid, but these teeth we're going to lose. That's the day of delivery, and that's a week later. Very aesthetic, very functional, an excellent appliance and an excellent technique. So space maintenance is important both in the anterior and in the posterior segment.